Stable angina. Stable angina, also known as angina pectoris, is a chronic clinical syndrome characterized by transient chest discomfort due to myocardial ischemia that occurs predictably with exertion or emotional stress and relieves with rest or nitrate administration. It reflects a fixed atherosclerotic narrowing of one or more coronary arteries that limits oxygen delivery to the myocardium during increased demand but remains adequate at rest. The primary cause is coronary artery disease, which is due to atherosclerosis. Other less common causes include coronary artery spasm, also known as variant angina, aortic stenosis, hypertrophic cardiomyopathy, anemia, which means increased oxygen demand, tachyarrhythmias, which means increased myocardial workload. Symptoms are typically provoked by physical exertion, e.g. climbing stairs, walking uphill, emotional stress, unhealthy meals, smoking or caffeine intake. Symptoms and clinical features include central or retrosternal chest pain, often described as tightness, pressure or heaviness, radiation to the left arm, neck, jaw or back. Symptoms typically lasts 1 to 10 minutes, relieved by rest or sublingual glyceryl trinitrate (GTN) spray. Associated symptoms are usually shortness of breath, diaphoresis, nausea or fatigue, no pain at rest or increasing frequency or severity, which would suggest unstable angina. Baseline investigation and diagnostic tests are electrocardiogram (ECG), which may show evidence of previous infarction or non-specific ST segment T-wave changes. Blood tests include full blood count, renal function, lipid profile, HbA1c, thyroid function tests. Note that troponin should be normal in stable angina and elevated in acute coronary syndromes. Chest X-ray is done to exclude alternative causes such as heart failure. Non-invasive testing include exercise ECG, also known as stress test. This may show ST segment depression during exertion. CT coronary angiography, now recommended as the first-line diagnostic test for suspected stable angina. Invasive coronary angiography remains the gold standard for diagnosis and assessment of coronary artery disease, especially when revascularization is being considered. It provides definitive anatomical detail of coronary artery stenoses. Management include lifestyle modifications like smoking cessation, weight reduction and regular aerobic exercise, dietary modification, that is, low saturated fat, increased fruit vegetables, limit alcohol intake, blood pressure and glycemic control, stress management and psychological support. Pharmacological management include symptom control, where first line is beta blocker, e.g. bisoprolol, or calcium channel blocker, e.g. amlodipine, diltiazem. If one is contraindicated or not tolerated, switch to the other. Second line include combination of beta blocker and calcium channel blocker, or add a long-acting nitrate, EEG isosorbate mononitrate, nicorandil, ivabradine, ranolazine. Prognostic or secondary prevention therapy include antiplatelets like aspirin 75 mg daily or clopidogrel if intolerant, statins, e.g. atorvastatin 80 mg, ACE inhibitor ARB, if patient has comorbid hypertension, diabetes or left ventricular dysfunction. Interventional management include percutaneous coronary intervention, also known as PCI, used for symptom control when optimal medical therapy is insufficient or significant stenosis on angiography, or coronary artery bypass grafting, considered for multivessel disease or left main stem disease. Management in general practice include taking a detailed history, perform cardiovascular risk evaluation, and rule out acute coronary syndrome. Initial investigations will include ECG, bloods tests like lipid, glucose, renal, thyroid, and calculate the Q-risk score. Then start baseline management like lifestyle advice and risk factor control. Initiate beta blocker or calcium channel blocker if indicated. Start aspirin and statin if no contraindications. Refer to cardiology for further diagnostic testing. Also, safety netting by advising patient to seek urgent medical help if chest pain changes in pattern, occurs at rest, or lasts longer than 15 minutes, which is possibly unstable angina or MI.